Good morning. So if seems like everyone can hear me, but if someone can just say hi in the chat just to make sure, it'd be helpful. We're using a new system this morning. Hi, Prague. Thank you. We're using a new webinar system this morning, so we're just making sure we don't have any trouble along the way. So please bear with us if we encounter any issues. You can type in the chat if you lose sound or anything seems to be going awry. I think there is a little bit of a delay, so that's the one thing I just will let everyone know now. Okay, yeah, so I'm getting the nod here in the room that the sound is good and that there doesn't seem to be as bad a delay as we were seeing earlier. If you can type into the chat, if you're in a room with a bunch of people, or just type in the chat if there's more than one of you watching there today, just trying to get a sense of numbers, and that will be helpful. If there's 3 or 4 of you watching together, just type it into the chat and let us know. So as usual, due to the number of participants, you guys are all muted, but feel free to type questions into the chat. We are monitoring that. I do have Noelle in the room with me as well, and she might jump in to answer some questions as we're going along. We will be posting a recording of the event and a copy of the slides as usual afterwards, hopefully within the week. We should be able to do that. And again, as usual, we haven't formally accredited this session, but you can document it as self-directed learning in your learning portfolio. And we have gotten some questions lately on what would be supporting documentation for that. So you can certainly use, a copy of the email that went out. If you registered for the event, that you would get a confirmation email, or you might get an email afterwards that says, thank you for attending. Any of those would be supportive documentation. If you or someone else watches it after the fact, so I guess you guys are watching it now, but for the sake of the people who might be watching this on the recording, that gets a little bit trickier, but we are thinking about working on a certificate that, a blank certificate that you could fill out and use for that purpose. But in the meantime, again, if you did register but then just didn't watch it till later, you could use that registration email. Noelle, other thoughts?
Or just a notation of when you watch the recording, and make sure that you still take down your notes around key messages.
Yeah, you still have to document it in your learning portfolio, just like you would any other self-directed learning. So it's just if you happen to get audited and you're looking for a piece of that supporting documentation, sometimes we've had questions on what to use for that. So
yeah, I think just a notation, whatever makes the most sense for the circumstance, a notation of when you watched it, because if you don't have anything else to provide, that would be sufficient.
Okay. So we're going to move on to our outline. So today we're going to focus on the standards of practice prescribing by pharmacists, and we are really going to focus in on the changes. So we won't be going through every detail of the standard, but I will be focusing on the changes. And I'm also going to throw up a couple of practice examples. Again, we're not going to go into those in any kind of detail. We're going to go through like what you would do, but we just wanted to kind of throw a few examples up there just so that you could see what types of things might apply. So just a little background on the prescribing standards and how we got here. So in June of 2010, we started with the medication management standards, and they were limited really to the community setting and only included interim supply, extension, and adaptation. So they were really focused in on, things you would do on the dispensing, related to dispensing activities primarily. Then in August of 2015, we approved prescribing standards to replace the medication management standards. So the medication management standards went away, and with the government, we worked on standards that are also enabled and limited by prescribing regulations. So that adds another layer of, I guess, legislation to the prescribing standards. So those prescribing regulations are approved by the Minister of Health and Community Services in collaboration with NLPB. So with this revision in 2015, we added prescribing for a minor ailment, as well as prescribing over-the-counter products and also therapeutic substitution. So those standards did add really kind of permitted prescribing in any setting, but there were still some operational limitations in the document. And we did get some feedback, particularly from hospital practitioners, that it was sometimes still difficult to apply the scopes in their practice because of some of those operational limitations. So that brings us to our most recent revisions. So we've been working with our Expanded Practice Advisory Committee and the government on revisions to the regulations and then subsequently to the standards since about the middle of 2017. It was a difficult process. Obviously, it took just over 2 years to really get through that process. So it was difficult, and we did have to make some compromises along the way in order to bring it to its conclusion. So in November of last year, we did get finalized revisions to the regulations, and with the goal of having them enforced by the end of January. And then the board subsequently approved revisions to our standards of practice to coincide with those changes to the regulations, as well as to address some of the other outstanding issues that we had noted along the way or had gotten feedback on. So all of these changes were announced by the department on January 30th, and we subsequently made an announcement to registrants via email and also was posted on our website. So just there's like this little screenshot there on the screen of the release that went out from the department. And then if you went to our website, there is also a little post there about the changes as well. So where can you find the information about all this? Well, here's where you will find it. It is on our legislation page. You'll find the regulations. Now, they're not yet posted. It takes government a little while to get the revised regulations posted because that has to go through the Queen's printer and the House of Assembly, and there's a whole bunch of steps there. So we're hoping that they'll be posted pretty soon, but they will go on a link will go on our legislation page once they're ready to go. The revised standards, though, are posted currently to our standards, guidelines, policies, and positions page. There have been some revisions made to our FAQ that's on our frequently asked questions about pharmacy practice page, and we will be adding more to that page. Right now it is just a basic FAQ, but we will be updating that as we get questions and certainly populating some more things into that. The prescribing orientation program that's on the learning portal, that's what you would have to do when you first get authorized. That's also been updated to reflect the new standards and should go live later this week. It's just going through some final tweaking. And, you're certainly welcome to take that program, even if you've taken it before. If you think that would be helpful to go through it again, you're more than welcome to do so. Okay, just having a look at the chat. Are we all good? Okay. Oh, there we go. So at a high level, what has changed? So these 4 bullets really kind of encompass at a high level, and I will be going into more detail on this. So really, as the announcement really focused in on I guess the biggest change was that a new section relating to prescribing drugs for a limited number of preventable diseases was added. So that was really the big focus of the announcement. But we have also revised sections related to assessment, documentation, notification and communication, and those sections really, a lot of the revisions to those was focused on the availability of the electronic health record. We also streamlined the adaptation section to clean it up a bit, but also to reduce some perceived limitations with regard to that category of prescribing. And all of the revisions were done with a specific focus on ensuring the standards are applicable to pharmacists beyond just those working in a community pharmacy setting. So, that may be, hospital, maybe someone that's working more in a clinic or a non-traditional setting. So really just trying to take out anything in the standard that may be perceived as limiting. So I'm going to take some time to go through the standards in a bit more detail, just section by section. And again, I'm going to be focusing on the changes specifically. So I do encourage you to go and look at the standards in their entirety, because I won't be necessarily delving into every piece of that. So the first section is focused on the requirements for pharmacists, and this section really didn't get any changes. This is the same requirements that we've had since 2015. So part of prescribing, pharmacists do need to apply to the board for authorization. Now, I will point out that if you're already authorized, you do not have to reapply. There's no reapplication process, so that's important to point out. There's no need for that. If you're already authorized, your authorization is still valid and still in effect. But you are expected to understand and know the changes. That is part of the declaration when you did get authorized, is that you would remain competent and fresh on the standards and the regulations. So it is important to make sure that you at the very least read through the new document, or like I said before, you could go and do the online orientation program just to refamiliarize yourself with the standards as a whole and any changes that were made. I do also want to say, just as a little disclaimer, that this webinar does not take the place of doing that orientation program if you haven't been authorized already. So you still do have to do the online program. Okay, so the limitations, again, this section hasn't changed. It's the same limitations that were in place before. So pharmacists may not prescribe, still may not prescribe narcotics, controlled drugs, drugs on the TRPP list, because there's a couple of differences there. The interim supply, extension, extend, or adapt if the prescription specifically states do not do any of those things. Prescribing for an animal or prescribing for themselves. So those are all do nots. And then the should not would be family member or someone of a close personal relationship, unless there's no alternative. And the standards do include, I guess, a note that says if you do determine that it's appropriate to do that, then you should document your rationale for that as part of your prescribing documentation. There was a section in the 2015 document that dealt specifically with operational standards. So that section has been eliminated, and some of the content that was in that section is just gone. And then other content was blended in to the, under the general standards section. So again, that was with the intention of reducing potential limitations and clarifying that prescribing is not necessarily confined to within a pharmacy. So I'm going to briefly go through some of the general standard sections. Again, most of these didn't receive a lot of revision, so I'm not going to go into a lot of detail on them. So the general standard section is divided into several subsections. The layout section is intended to be less restrictive than it was before. Again, this could be a private counseling room in a pharmacy, but it could also be a clinic office. It could even be bedside in a hospital. It's really focused on, the assessment, the consultation piece of that prescribing when you're actually having a conversation with a patient about it. So, you may have a short conversation with the patient and then go off and do the actual documentation somewhere else. So, there may be two pieces to that. The informed consent section was revised to remove a specific reference to the documentation and notification form, and I will talk about that a little bit more in a couple of slides. And there was no revisions made to the competency and code of ethics section. So based on feedback, we did add more detail to the section on appropriate knowledge and understanding, particularly pertaining to the assessment and what the assessment should include and how it can be obtained. We have received a number of questions on that over the years. And, you know, we did kind of do, I guess, with the committee and also with some consultation, we did kind of poke around in that a bit more and, you know, really tried to clarify that and make it, I guess, a bit more open-ended, and that you may gather that information entirely through communication with the patient. It may be a combination of a number of sources. You could be using the electronic health record. You know, there's a number of different pieces that should be being considered as part of that assessment. The section related to whether or not the prescribing is appropriate for the patient, that section wasn't changed at all. So while the principles of follow-up were included in the former standards, we did add a new section that deals specifically with creating a follow-up plan appropriate to the circumstances. And I did want to say that follow-up plans don't necessarily need to be complicated. Sometimes follow-up can be very simple, but at the very least, it should include detail, who's doing the follow-up, you know, how they're going to follow up, what, you know, when is the follow-up going to occur, what's your targeted outcome. So there's just some basic principles of what should be included in that, but it doesn't necessarily have to be complicated. So for example, when prescribing for a minor ailment, a pharmacist might plan to follow up with the patient by phone or ask the patient to come back in to the pharmacy at a specific time in 2 or 3 days, for example. And, you know, the point of that would be to determine if the symptoms have resolved, if there's a need for additional treatment, if referral is necessary. So, you know, again, can be a very simple thing. You know, you're going to come in here in 2 to 3 days. I'm going to reassess your symptoms and we'll determine where we go from there. Alternatively, when a pharmacist is extending a prescription, for example, you may not need to have a detailed follow-up plan. But it may be that you determine that that person might benefit from refill reminders or, you know, compliance packaging, or there may be other things that might come out of that. So it's not necessarily a detailed follow-up plan specifically related to the extension, but it might, you know, spark, I guess, another thought. The documentation section did get some fairly extensive revisions, and it now includes details, you know, as to why the documentation is important, when and how it should take place, and also what should be included for documentation to be effective. We have removed the template documentation and notification forms, so there's now no requirement that you specifically requires pharmacists to use that form or that template that we had included in the previous standards. So pharmacists can develop or use their own form if they like. There are electronic resources we know that are available in a number of the practice management systems. They have some templates included now in those. The electronic health record has some resources that you can use. There's, you know, an add pharmacy service tab in there that you could use for your documentation. You could also add a note in on the actual prescription itself when you're dispensing it. So there's a number of different places in the electronic health record you could use. I think we are going to keep a generic template. We have gotten some interest in the form that we did have, but it will be pretty generic. So we'll post that on our pharmacy practice resources page once we have that ready to go. It may be a week or two, but we will probably put something together just for those that would like to have a template still. Regardless of the method that is chosen, though, documentation should be completed so that others that would be looking to access that information have a clear understanding of the prescribing activities and the pharmacist's rationale and related follow-up, especially if you're working, you know, in a collaborative environment with a number of other pharmacists where someone else may need to be the one doing that follow-up. If you're not working that shift, for example, the patient comes in and you're not the one that's there, it should be documented in a way that another pharmacist on the team can do that follow-up if necessary. So the previous section that was devoted to notification is now focused on communication. So active forms of notification, such as faxing of the forms. So we had the former template was called a documentation and notification form. And the idea was that at the time was to simplify that so it was one and the same. But really, those are now teased out as separate activities. So the active forms of notification are no longer required unless you determine that that's appropriate with the prescribers that you're working with, then certainly you are able to still do that. But the majority of pharmacist prescriptions are added to the patient's profile in the electronic health record at the time they're dispensed. So really, because now other health professionals such as physicians, nurse practitioners, nurses, and even some other health providers have access to that information through their access to Health E&L. So there really I guess the active notifying via fax really wasn't necessary anymore because other health professionals have access to that information at the time of dispense. So in hospital settings, however, we do know that doesn't always happen in that same way. So we've had some consultation with the hospital groups, and certainly there may be other sources, other systems that are being used internally within the hospital to communicate with the health professionals you're collaborating with. So that may be the patient's centralized chart, so in a paper form, or that may be their electronic health record within the institution. So there may be different forms, but that's fine with the standard. So maybe just that's something you would have to talk to the team of prescribers that you're working with to ensure that if there's some other way that they prefer to use, then that's the system that you would use. So just a moment just to kind of delve into all that a little bit further, because again, documentation and notification really were, documentation, formerly were documentation and notification. So those two principles were tied together. But really, documentation and communication are two separate activities that have different purposes. So documentation, the main purpose for that really is to establish your own accountability and responsibility for professional activities. So that could be, like I said, within your own pharmacy team, you may need to communicate with each other. So your documentation would serve for that. Or maybe, hopefully not, but in the case that there was ever, a complaint or something was to come back in that you need to document your, show that your documented rationale. So it would serve for that purpose as well. So it's really your own accountability. Whereas communication is really focused on the collaboration with other health professionals. So the pieces of information that you would share may not necessarily be the same. So while they were tied together previously on the form for simplicity, we're pulling those things apart. So, everything you document does not necessarily have to be communicated. You may choose different pieces of information. So communication is really focused on, what that health professional needs to know. So they might not necessarily need to know your entire prescribing rationale and your assessment that you did. It just may be as simple as I prescribed this to this patient on this date. And most of that is included, like I said, when you do your dispense. So it would only be if you felt there was some additional pieces of information that would be useful. Then, like I said, you could use that note field. When you're doing the dispense, there's the opportunity to add a note there. So you could put something else there. Or, again, it really depends on if you're working in a team. If you're working in a collaborative team, then you might decide, okay, no, we want everything shared within the team. So then that would be determined, collaboratively with that team environment. Understand this can be very specific to individual circumstances. So I did want to say, if in your own practice, if you're not quite sure how some of this would apply in your practice, certainly feel free to reach out to us, and we can help walk you through it and help you figure out how it will best work and what makes sense within your own environment. Because for the most part, I think for the average community pharmacy dispensing, for most of these activities, the communication will be more or less limited to what you're dispensing. But there may be other, individual circumstances where you might want to figure out how to use, like I said, that professional services tab, or use the notes screen, or some other form that we're not even really aware of at this point. So just certainly reach out and we can talk you through it. Okay, so that's it for the general standards section. I'm going to jump in now to the standards that are specific to the individual categories of prescribing. So as I had said, the only new category that was added was the prescribing for preventable disease. However, all the other sections really were tweaked in one form or another. We really streamlined the appropriateness sections. There was a lot of, I guess, repetition and some redundant information in that section that really repeated a lot of what was already said in the general standards. So we reduced that down, and also tried to again remove any limitations, anything tying it to a pharmacy site, for example. And again, the individual sections made reference to documentation and notification. So again, we eliminated that information, and really you're expected to rely on the principles that are in the general standards section. So just to take each section at a time. So prescribing for a minor ailment, this section didn't get any revision really. We tweaked the list slightly just for some clarification to wording on some of the conditions. And but there's no new ailments were added at this time. It is still part of the ongoing piece of work with the department though. So we are hopeful that we will get some additional ailments over the next, I'll say, a year, but again, as with everything, these things can take time. So we're certainly hopeful that we will get some additional ailments added, but they weren't included in this particular revision. So as I had said before, I'm just going to throw these up there. And again, in the interest of time, I want to make sure we have time for questions. So I'm not going to go through them in any kind of detail, but did want to just give you a couple of examples after each section on just a couple of simple ways that we think that you could use each of these prescribing categories. So as I had said, prescribing for preventable disease is the new section that was added. And this new scope permits pharmacists to prescribe for 4 additional preventable diseases above and beyond what was already permitted. So we had the permission in the previous standard to prescribe Schedule 2 products. So because of that, a lot of the vaccines are included in Schedule 2. So you already had that authority for example, influenza, that sort of thing in the cholera vaccine. Those were already included in the 2015 standards. But we have added in hepatitis A and B, herpes zoster, which is the shingles vaccine, and the varicella zoster, which is the chickenpox vaccine. So those were additions. I will make a note that HPV is a funny one, because when we started this work, it was included in Schedule 1, so it is on the list, but it actually has moved to Schedule 2 since then. So it's kind of included under both scopes really, but it is a Schedule 2 vaccine. So you could prescribe that now regardless. Here's a couple of quick examples. So again, the flu shot, which was included previously, and also now with the shingles vaccine. So this doesn't change anything related to the injection standards. You could have injected both of these previously pursuant to someone else's prescription, the shingles in particular. But now it's something that you can also prescribe yourself as well as administer. prescribing Schedule 2, 3, or unscheduled drugs. So this previously included specific reference to situations of adherence or reimbursement. So it, again, was potentially limiting to just those situations. So those restrictions have been removed, which gives pharmacists a bit more flexibility on using this particular scope. Another couple of examples, one pertaining to an aero chamber, where you're replacing a previous aero chamber, and also we do get, actually, we've gotten a fair number of questions over the years around diabetic supplies. So again, clarifying that, yes, that can be something that a pharmacist can initiate a prescription for. It's not a drug per se, but it would be still included. Interim supply. So we made, I guess, a fairly minor revision here, but it certainly was something that we've gotten questions on, and that is that the previous standards had limited this to conditions that were considered chronic or long-term. So that phrasing was used, which again was potentially limiting. I'm trying to blend two words there. So we did remove that restriction because it was subjective, you know, in some ways, you know, what does that really mean? What does chronic mean? What does long-term mean? So sometimes that can, you know, can mean different things to different people. So we removed that specific limitation. And similarly with extending a prescription, we did the same. So we also removed the restriction there for chronic or long-term. Both interim and extending both still say that the patient has, you know, a stable compliant history with the medication, but that's really more subject to what the medication is. You know, what that means for, you know, a blood pressure medication would be very different than what that means for an inhaler or a topical cream. So, you know, it's not tying it to that chronic, it's not tying it to that long term. It still may be more of an acute condition, but that the history with that particular medication, that particular condition makes sense, I guess. And also the extending prescription section was previously limited to prescriptions that had been filled at the particular pharmacy where the extension was taking place. So that limitation has also been removed. So you don't necessarily have to, I'll put air quotes around this, own the prescription in order to give an extension. So it, you know, it's more similar to interim supply in that way, that you can now provide someone with an extension, even if it's not a prescription that was filled in your pharmacy necessarily. The main reasons for that was a limitation for hospital practitioners. And it was determined really to be no longer necessary because of the access to the electronic health record and the information that's in the pharmacy network. So really, you know, you have access to the same information on those prescriptions as you would the prescriptions you filled yourself. So. Just a little screen, because we recognized as we worked through this that because of some of the revisions we made, there's not really as much separating interim supply from extension anymore. And that may be something that evolves over time, that, you know, we may blend those two at some point in the next revision in another, you know, 5 years time. That may be something that gets blended together in a different way, but sections do still stand alone at the moment. But I wanted to just do a little quick slide on just some of the, I guess, differences or just some of the ways that they can be used together. So generally speaking, it really comes down to quantity now, you know, on which, you know, whether you're giving an interim supply or an extension. So interim supply is said to be the minimum necessary quantity, while an extension would be given if you wanted to more or less give the same as the last dispense, or, you know, something at a higher quantity. And we do know, and based on the questions we get, that there is some confusion about, you know, which one I should use, when I should use it, you know, can I use one if I've already used the other? the patient comes back, for example, and their appointment got changed, or who knows, we had the snowmageddon, situation where we were certainly, in situations where patients were stranded, and, maybe, initially didn't think they'd be stranded as long as they ended up being. So there's all sorts of situations where you may have to, revisit what you've already done. So the only absolute limitation in the standards is that it says that you cannot extend the prescription that's already been extended. So that's something that is in the regulation and is in the standard. So that's the only thing that's an absolute, you cannot do that. The other things are really, I guess, open to your professional judgment. So, you can give an interim supply to someone if you've given them an extension and for some reason they need, an additional couple of days. If their appointment got changed or they missed it for some reason, there's a snowstorm, whatever the case may be, you can, supplement, I guess, that extension with an extra couple of days with an interim supply. Or, alternatively, if you've given an interim supply, you can give another interim supply if again, that's the most appropriate thing. There's no limitation that you can't give a second interim supply. Potentially, and I'll kind of, again, put that in the air, the air quotes, you could potentially give an extension. It's probably less likely that you would give an extension following an interim supply, but it is a possibility. It is something that the standards do not necessarily say you cannot do. So if, you determined that that was appropriate for some reason, if maybe they originally thought the appointment was going to be in a couple of days, but then due to some sort of circumstance, it's now next month or something, there may be some reason why you might determine that an extension would be the way to go in that case. Just a couple, again, quick examples. And these will all be in the slides too. So when we post the video, there'll be a copy of the slides posted as well. So if I'm going through them too quickly for you to read, we'll be able to get them then. Adapting a prescription, we definitely did a fair bit of revision on this section, and really the most significant revision we did was to take out a lot of the examples, because while originally we had thought the examples would be helpful in people understanding when they could use some of the different elements of adaptation, it really ended up being that a lot of people viewed them as limitations, that was the only circumstances that they could do those things. So we really cleaned up this section and kind of reformatted it to a certain extent. So the revised language is a bit more open-ended and really puts the, I guess, decision-making in the hands of the pharmacist. So it really is intended that this section is not necessarily meant to be limiting. It is meant to be empowering and give pharmacists more ability to help their patients, and certainly reduce the number of situations where pharmacists would have to call or send a fax to get something approved, a change approved. So it really is meant to be addressing those, I'll call them those common sense or those simple things where really what the change needs to be. And it just, rather than having to send off for, a physician to sign off on it, you can do it yourself. So that could be missing information, could be something that happens in a situation of a drug recall or a back order, a dosage form preference, obviously, changes to the regimen for adherence, so someone, putting someone on a once a day formulation instead of a 2 or 3 times a day formulation. So some of those things that, it's really intended for you to be able to help your patients to do what's best for them. It also allows pharmacists now the ability to adapt the prescription based on patient-specific factors such as weight or organ function. Other medication may be causing a situation where the dose needs to be adjusted for some reason. So it gives pharmacists more, I guess, again, empowers pharmacists to do that. If you have access to that information and you're feel competent to apply that, then certainly that is within your your ability to do so under adaptation. And just on that note, a couple of more examples there. Okay, therapeutic substitution, not a lot changed for this category, other than the fact that it was, again, previously limited to prescriptions that had been located at that pharmacy if it was based on a refill. So, I mean, obviously, if you have the original fill and you're therapeutically substituting, but in some cases you may have filled the original according to the prescription, but then need to therapeutically substitute upon refill. Again, that could be due to a recall or you know, a back order, or some other information that's out of your control. And certainly, again, the previous standard was had limited that to prescriptions you had filled, but now that limitation has just been removed. So, you know, if for some reason they're coming to you at the time, it's possible to do so. And again, it's just a couple of examples. Back order, I mean, that's probably a pretty common thing these days. I did want to say, and I think we included it in the, I'm not sure, I'm trying to remember where I included it, but I did include a note either in the FAQ or in the online program that one of the questions that we get on this is whether or not it's restricted to the same class. And I guess that's something to make sure everyone is clear on. Is you don't necessarily have to substitute within the same class. The standard says that the outcome has the same therapeutic effect. So, for example, you might need to therapeutically substitute, one antibiotic for another due to an allergy, for example. So, you know, you can do that. That is possible as long as, you know, the outcome would have the same effect. So obviously you'd want to, you know, ensure that it's still an appropriate antibiotic for whatever the infection is. But it is something that we've had questions on, and I did mean to make a note to mention that. So just a couple of misconceptions, and we actually included these a while back when we did a little myths and misconceptions webinar, probably a year or more ago now, but some of these we discussed at that time, but I did want to bring them up again. And that was, so really all of these are all false. So pharmacists are not permitted to prescribe psychiatric medications. That comes up a lot. The only limitation there really is tied to benzos. So that's just something to be aware of, that, you know, if someone is taking an antidepressant or, you know, something else that for some reason falls in under that, you know, psychiatric heading, there is no limitation on that. In some provinces there is, so I don't know if that's where the confusion comes from, but in Newfoundland there isn't a limitation on that. We've also had people think that they can't put refills on their prescriptions, or that if they adapt or substitute a prescription, the refills that were on it aren't valid anymore. So none of that is true. Again, I've already mentioned that, you know, people have had the thought that, you know, if they've extended a prescription, that's it. That can't do anything else for the patient. So we wanted to make sure that was clear that that's not the case. Oh, and I did include it here. So the therapeutic substitution is not limited to the same class. Again, that's a misconception that some people have had, that they seem to think that it can only be the same class medications, but that's not the case. So now we have a bit of time, just to keep a time check. So we've got about 15 minutes. If there's any questions, has anything come in on the chat, Amanda? No, so we haven't had anything in the chat, but certainly if anyone wants to take a minute to type anything into the chat there, we do have a little bit of time to answer some questions. Like I said, if nothing is jumping to mind now, but you think of something afterwards, feel free to reach out to us. and we will be posting this after. So sometimes you might rewatch it or have a look at the slides and something might pop up in your mind. Okay, so there's a question there about if you give a full extension. So if you give an extension of 90 days and need to do an interim supply after, yes, yep, so that would be fine. Again, you know, your interim supply would be expected to be limited to the minimum necessary, but if there isn't, it's not like, okay, I've hit 90 days, I can't do anything else. There's nothing specific in that. The 90-day restriction really is just related to the extension itself. So someone is asking about when prescribing diabetic supplies or an aero chamber. Yes, so you would, regardless of what type of prescribing you're doing, you still need to document. But again, when you say the same sort of documentation, your documentation is dependent on what you're prescribing and when and to who. Like, it's subjective really on what you're doing. So obviously, if you're doing prescribing a diabetic supply or an aero chamber, your assessment is probably not going to be as extensive as your assessment would be if you're initiating therapy for a minor ailment, but you still would have to document it. Okay, just following up.
Oh, no, you missed a train.
No, you can't extend benzos, but the question, I think the misconception you're probably thinking about is with regard to psychiatric medications. So a lot of times people think they can't do anything with anything that would fall in under this psychiatric heading. The only limitation within that would be benzos. So again, pharmacists cannot prescribe. So that includes, extend, adapt, anything related to these standards for controlled drugs or substances, including benzodiazepines. So I'm trying to follow the question Allison has on the documentation. So how do we carry that documentation over to the electronic health record? So you don't necessarily have to. You are documenting for your own record, for your own purposes. You would do that documentation within Kroll for your own documentation purposes, your own accountability. Then if you're in a community pharmacy, you would be then filling that prescription through the electronic health record. So that's the communication piece of that. If you're not in a community pharmacy, if you're prescribing and then giving the prescription to take to someone else to fill, that would be sent then. So that's when the communication element is tied more to the information you'd want to share with other health professionals. So it would only be if you felt there was some additional piece that you wanted to communicate beyond just what would be part of that dispense. So someone is asking about credits for CEs. So you can document it as self-directed learning in your learning portfolio. Can a pharmacist indicate no substitute? I'm not quite following. Noel, do you follow that question? I'm not quite following that question, Leslie.
I think she may be asking if a patient has a preference for a brand, can a pharmacist assign no substitute to a prescription that they didn't originate?
For brand, yes.
So I guess you can adapt the brand. Under adaptation, you can adapt the brand, and you would just, I guess, document that as patient preference.
I think
if we're not getting it, Leslie, give Noelle or I a call after if we're not quite getting what your question is.
The important thing to note there, though, is while that may be permissible under our standards, whether that makes a difference to coverage,
right?
We wouldn't be able.
Yeah, we can't really. Yeah, that would be third party specific, I guess, as to whether they would accept that. Yeah. Anyone have information of reimbursement? Yeah, so we don't really know about reimbursement side of it. Again, panel, that would be someone from panel would be able to give you that information. So best bet really would be to contact panel.
They have had some,
Yeah.
maybe look back through some of their weekly updates, because they've had some comments there and some activities they're pursuing in that area.
Mentioned out-of-class adaptations. So we can switch antibiotics without confirmation from a physician. Yes. Yep. So the standard requires that, and I'm just gonna open it up just so I have the exact wording. But the therapeutic substitution is not restricted to class. So it says that the pharmacist must be reasonably satisfied that the substituted drug will have a similar therapeutic effect as the prescribed drug. So you know, if someone has a penicillin allergy and you need to switch them out to a different class, that's fine, as long as you know that that's the appropriate antibiotic for that. If they have a sinus infection, for example, that you know that it's still going to have the same coverage, then that's perfectly fine. Years ago in the standard, sorry, I'm reading the question, so sorry if I'm not talking for a moment. Yeah, so there's nothing now that says that you have to keep the original prescriber's name. There just doesn't reference that anymore specifically, because again, it may make sense in some situations, but it may not make sense in others. So really you would do what makes the most sense in that situation. You know, ideally we would see pharmacists taking responsibility, you know, for their adaptations, especially if you're doing, you know, something that is more than just, you know, changing the, I guess, you know, brand, or the cream, a cream to a liquid, or, you know, not a cream to a liquid, but you know what I mean, cream to an ointment or something like that. But yeah, that was under, I don't even know if that was in the 2015 or if that was on, if that may actually go back to the 2010. Yeah, for every extension I do, I send a fax off to the doctor. That's correct. Yep. So I can't see who sent that question, but yeah, for an extension, you don't need to send a fax specifically anymore. If you're doing an extension and you're filling that prescription within the pharmacy, oh, that's Tara. You don't have to necessarily send that fax off anymore, unless for some reason, like I said, you in discussion with that prescriber determine that's the most appropriate method. But generally speaking, no, it's not a requirement anymore. Sure. Sorry, I'm trying to get through them quickly and I'm not reading the actual question. So we've got a question on under adapting a prescription, am I able to change the dose of an antibiotic to account for renal function? So yes, that would fall in under adaptation for dose, because you have that patient-specific factor that you may need to, you know, for example, decrease the dose because of the patient's renal function. That is permissible.
As long as you have the information.
Yeah, as long as it makes sense and is appropriate to do so, obviously. Yeah. So there's insurance companies that will not accept pharmacists writing no sub. Okay, so that's related to the previous question about no substitute. So again, yeah, that's really probably going to be insurance company specific. So you're best to follow up with the specific company if there's issues there.
If a specific insurance company did have questions about whether that was within our provincial scope, then they can certainly be referred to LPB office for clarification, so that perhaps, you know, we could, you know, facilitate some clarification around that and broadening of that, but it wouldn't be part of NLPB's decision making. That would be rest with the insurance.
But we have done that in the past, you know, if there's something that they're not quite sure how they can apply it. You know, we've had those discussions with some of the companies in the past, especially when these were new standards. So if the doctor writes a strength, i.e. Crestor 10, and the patient usually gets Crestor 5, was not expecting a change, can we adapt to indicate Crestor 5 without confirming? Yes, that would be an appropriate circumstance. If you feel that based on the information you have, that there's no reason for that dose to have been changed, then that perfectly fits within the adaptation. category.
One thing to think about in terms of your decision making around whether you need to provide additional information to a primary healthcare provider besides just transmitting that prescription to the electronic health record. Think if you're changing someone else's initial decision, that might be something where you would want to reflect on whether some additional notification information is necessary so that the patient's chart within their office is also accurate with respect to what medications they've been prescribed.
Or, you know, certainly Leslie's last question around if you think maybe the physician has it charted wrong, you know, if you've noticed, okay, this is the second time I've had to adapt it back to 5, maybe that's a good time to either follow up to make sure that it's not meant to be changed, or, you know, if you think that they need to make a correction in their own chart, you know, that would certainly be a good opportunity there to send a more specific notification over to them.
And I think you'd really want to be as certain as you can be that you've got sufficient information that it wasn't an intentional change.
Yeah.
And that's going to depend, I think, on the patient's medication history and that your relationship with that specific patient as well.
Yeah. Again, you know, the reason, or part of the reason why we've eliminated that form and remove the requirement for a specific, faxing within a specific time frame is, you know, we certainly had feedback from physicians as well, and I'm sure many of you did also, that, you know, just like everyone, they're inundated with paper as well. So, you know, I would, you know, the idea with this is not to say you never fax anything, but I guess it's to give you more control over that so that you reflect on it and think, when is this appropriate? Is it appropriate for me to send this every single time I'm just doing, you know, a simple interim supply or a simple extension? But certainly, you know, in those cases of adaptation, that might be somewhere where you take a step back and think, yeah, this might be a better place for me to actually send something more direct, more specific.
Or even perhaps therapeutic substitution.
Yep. Therapeutic substitution is another great example of that. You know, again, sometimes it may be so they correct their record. It's possible that, you know, they weren't aware the person had an allergy to that medication, or, you know, it might be great information for them to know this product is back ordered and doesn't have a release date, you know. So all that, it's all is meant to be in the spirit of communication and collaboration, so that everyone has the information they need, but isn't necessarily being bombarded and you know, inundated with information that they just can't process. So it looks like we might have gotten, oh, wait, no, maybe one more. Yes, so that would still, there was a specific, again, under the old standards, it was very specific. We had some really specific examples. So we've taken out those specific examples, but, you know, anything that, you know, if something's not commercially available anymore, and, you know, used to be and now it isn't, or like you said, you know, something makes sense, then you can certainly adapt for that. Okay, so we're hitting 11 o'clock, and I think we're at the end of our time. So if anyone has any other specific questions, you know, certainly feel free to reach out to us. You can send an email, you know, to our InfoRx account, or you can, you know, certainly reach out to myself or Noelle directly. And, you know, we'd be happy to help you through any of this. Again, like I said, if you want to take the extra step beyond this webinar and do the online orientation program, again, there's more specific examples in that, as well as the ones we've talked about today. So there might be, you know, might be beneficial to do that. You can certainly feel free. Like I said earlier, I hope to have that posted by the end of the week on the learning portal. And we'll be updating the FAQ. You'll see Noelle and Russell out in your sites. So there's lots of opportunity to ask questions. And Ken, yes, out in your sites. Sorry, Ken. So, you know, you'll certainly be, have an opportunity to ask questions, and, you know, it'll take some time to get used to the changes, I'm sure. But the goal is that this is a more user-friendly document, hopefully, and that you are empowered to do more for your patients and don't have as much limitation when doing so. So thanks everyone for joining us today, and we'll be talking to you again soon.